Continuing on with our patient assessment, once you've made sure that the airway is open and that they can keep it open, then you're going to assess breathing. You want to ask yourself not only is the patient breathing, which obviously is the most important, but if they're breathing, is their breathing adequate? Are they taking in enough air? Is the patient hypoxic? Are they not getting enough air even though they're breathing? A patient who is breathing without assistance is said to have spontaneous respirations or spontaneous breathing. And that's kind of what we're hoping for. When a patient is either not breathing, breathing on their own, but not breathing adequately, we should consider a positive pressure ventilation with an airway adjunct. So positive pressure ventilations are achieved through the use of a bag valve mask. Just as a general rule, if a patient's respirations are faster than 28 breaths per minute, then we should assist in ventilation. When a patient starts breathing that fast, even though they're taking in oxygen, they're breathing it out so fast as well that they're not taking in great volumes of oxygen. They can't take deep, normal breaths because they're breathing so fast. On the contrary, if they're breathing under 8 times a minute, they may be allowing their lungs to fill because they've got more time now, but they're not breathing often enough to get enough oxygen in their body to take care of everything that their cells need to take care of. Our goal for oxygenation for most patients, now this isn't all patients, it's most patients, is looking for an oxygen saturation approximately 94 to 99%. If they're doing this on their own, they're good. They don't need oxygen. If they're not, we may need to help them out. Keep in mind that hypoxia or lack of respiratory effort, those are signs. Those are things that we can actually see and observe. If the patient says that they are short of breath, shortness of breath is a symptom because you can't actually definitively measure shortness of breath. It's how they are feeling, so they're going to tell you. Any patient that is short of breath gets oxygen, even if it's just a little bit, because we're treating the symptom of shortness of breath, not the sign that they are hypoxic. You want to observe how much effort is required for them to breathe. They may be having retractions. We did talk about those earlier, where you see muscles actually moving in order to help them breathe in a way that's not normal. The use of accessory muscles, so using more than just the normal set of muscles to breathe. Nasal flaring, their nose might actually flare open as they try to get more air in. 2 to 3 word dyspnea. Dyspnea is just trouble speaking or difficulty speaking. 2 to 3 word, they get out 2 words, they get out 3 words, and then they have to breathe. Generally going to be a gasping breath and compared to a normal breath. The patient may end up sitting in that tripod position. They may be in the sniffing position. They're not necessarily bent over, but they have their head slightly tilted back. This is going to put their airway in a straight line and kind of facilitate them getting that air in. Air takes the path of least resistance into the body. So if they align their airway, there's more of a chance that it's going to go down the trachea and into the lungs rather than going down the esophagus. Most of the time, the esophagus will collapse on itself when there's not something actually going down, which makes more resistance for air to go down, so it does naturally want to go into the trachea. But if you're breathing forcefully, or if we're giving positive pressure ventilation to our patient, it may not necessarily be that way. Respiratory distress is any increase in the work of breathing. So this could be that they are having an increase in effort to breathe or an increase in the rate for how they're breathing. Respiratory failure is when the oxygen amount in the blood becomes inadequate to meet the oxygen demands of the body. So either they're having problems with respiration and perfusion at the cellular level, or they literally just cannot get in enough oxygen to keep up with the body's demands. The ultimate result of respiratory failure is death if it's not corrected. So definitely something we want to correct. If there's a problem with breathing, we won't move on to circulation. We will try and fix the breathing. If we can't fix it, then we need to assess circulation, but we need to be going. If there's a problem with A, B, or C that we can't fix, the patient is a critical transport and we need to initiate right away. We can do the rest of our assessment in the back of the ambulance while we're on our way to the hospital. The next step is assessing circulation. In order to assess circulation, you're going to look at the patient's mental status, their pulse, and their skin condition. So mental status, like we talked about just a few videos ago, if they're not getting enough oxygen to their brain because they're not getting enough blood to their brain, their mental status is going to change pretty rapidly. The pulse, we're going to assess how the blood is pumping out of the heart. It actually can change with what's going on with the body. And then skin condition, we'll go into that a little bit more, even though we have talked about shock. Assessing the pulse, remember that's the pressure that's exerted against the arteries when the heart pumps blood. First, you want to palpate, which means to feel. You want to feel the pulse. In patients that are greater than 1 year old, you're going to want to feel the pulse at the wrist. If they have very low blood pressure, you're not going to be able to feel that pulse at the wrist. So if you can't feel a pulse at the wrist, does that mean that they're dead? No, especially not if they're looking at you. It just means that their blood pressure is so low that they're not producing a peripheral pulse, or there's some sort of obstruction that's keeping adequate blood pressure to get to their arm so that they have a radial pulse. The next thing that you're going to do if you don't have is you're going to move up and palpate the carotid pulse in the neck. If they don't have a carotid pulse and they're not looking at you, they're unconscious, they're not breathing, we're going to go ahead and begin CPR. In patients that are under 1 year, you're going to check the brachial pulse, which is on the inside of that upper arm. It's super hard to find a radial on them because they just have these fat little arms, and you're not going to find it. If you go in the neck and you end up pushing a little bit too hard on a kid, you can actually occlude or pinch off blood to the brain. Plus, they have these big old shoulders and thick little necks that aren't very long, so it's hard to do that adequately. So for kids that are under 1 year, we just go ahead and use that inside of that upper arm. If the patient has a pulse but isn't breathing, then we'll initiate rescue breathing. We're going to breathe for them every 5 to 6 seconds, for an adult, every 3 to 5 for a kid, trying to maintain a ventilatory rate of 10 to 12 per minute for adults and 12 to 20 for kids. So just a little bit faster. That 5 to 6 seconds will seem unnervingly long, but you need to count it out and count it out loud. We need to be vocal on our scene so that everybody's on the same page. So don't forget to count it out. If the patient doesn't have a pulse and we begin CPR, you need to think about grabbing an AED. We will do CPR class during lab, so you'll get exposure to that. Chapter 13 also covers that situation. Skin condition. So you want to look at the patient's skin color, temperature, texture, or the amount of moisture, and then capillary refill as well. When it works the way it's supposed to, your blood perfuses the skin, which gives it the color that it has. So generally, We are pink, we are warm, and we are dry. Deviations of that may be just that we're in a different environment and our body's reacting, but as a general rule, pink, warm, and dry. You can be able to determine the amount of blood circulating through vessels based on the type of pigment that is seen on the skin. If the skin is pale, white, ashen, or gray, that means that there's not enough blood getting to the surface to actually perfuse all of that skin. Patients that are having problems with blood pressure tend to be pale, cool, and clammy. You can also get a bluish color called cyanosis. We've talked about that before. The most common places to see cyanosis are going to be in the nail beds or around the lips. If you see this, your patient is not getting enough blood or not enough oxygen in their blood. Skin temperature, normal skin will be warm to the touch. The average is 98.6. Anything that's really close to that, we're not too worried about. Any abnormal skin temperatures are hot, cool, cold, clammy. Remember, is that little bit of wetness to it. Diaphoretic is another term that is sweaty. And we can talk about that here in just a second. Dry skin is considered normal unless you're exercising excessively. Then obviously you're going to sweat a little bit. But skin that is wet, moist, or crazy dry and hot is not normal. Like I said, diaphoretic means that you're sweating profusely. Checking capillary refill. This is checking the ability of the body to restore blood to the fingertip. Obviously, the fingertips are peripheral on the body, so if you've got decent perfusion, you should be able to pinch a person's fingernail, have it go white, and then return to color very, very quickly. So here's a representation. When you're actually pushing down on it, you're actually squeezing blood out of those capillaries, which is causing the white color. Once you let go, it should very quickly turn back to a pink or a red. Normal is within 2 seconds. Once you start stretching out longer than 2 seconds, you know that there's an issue. The other thing that we want to look for is profuse bleeding. This says in trauma patients, but really we should look for all patients. There could be severe bleeding. If there is severe bleeding that you can see right away that could be life-threatening, go ahead and take care of it. Then go back to airway and circulation, or airway and breathing, excuse me. You can kind of tell where the blood is coming from depending on what it looks like and how much is coming out. Bleeding from veins tend to be more of an oozing type blood and also tend to be darker in color because there's not a whole lot of oxygen in it. If bleeding is coming from an artery, it tends to be spurting, which corresponds with the pulse, and it tends to be a brighter red in color because there's adequate oxygen in it. You can control bleeding by either applying direct pressure. You can put a gloved hand over top of it until you get some dressings. Put on some dressings. If they are continuing to bleed and they bleed through the dressings, you should always leave the one that's in contact with the wound in place. Replace all the other ones, but leave that one because you may have clotted to it. If you need to, you can apply a tourniquet if direct pressure is not quickly successful, or if you can tell that there is arterial bleeding for sure. That's going to be hard to control with direct pressure. We will continue in the next video.